guys, it's Medicosis Perfectionalis, where medicine makes perfect sense. Let's continue our anesthesiology playlist. In previous videos, we have talked about general anesthetics, regional anesthetics, and today it's time to talk about local anesthetics. We'll also review neuromuscular blockers. With that said, now let's get started. So in the good old days, which were not so good, doctors actually used to spit freaking coke into your wound, and that was the first local anesthetic. General anesthesia is not the same as analgesia, because analgesia means no pain. General anesthesia means no consciousness. Local anesthetics, of course, are anesthetics. They will make you numb. However, neuromuscular blockers are neither anesthetics nor analgesics. Anesthesia, care phases, pause and review, because we have talked about this before. Anesthesia is general, regional, or local. General is either inhaled or IV. Regional, neuraxial, limb, or others. Local, now we're talking about esters or amides. Other doofuses will call them amino esters and amino amides. Do you remember regional anesthesia that was discussed in the previous videos? Yup. What kind of agent did we use? A local anesthetic. In other words, local anesthetics can be used as a regional anesthetic or as a local anesthetic. Same medication, different approaches. What did we use here? A local anesthetic. What did we use here? Also a local anesthetic. Now, don't you want to learn more about local anesthetics? Anesthetic drugs, general or local? We're talking about the medications, not the approaches. How do general anesthetics work? They are pro-GABA, and GABA is inhibitory because it invites chloride into the nerve. Whenever you invite a negative into the nerve, the inside of the membrane will become more negative, which means inactivation, #hyperpolarization. Local anesthetics, on the other hand, work by inhibiting the sodium channels, not stimulating, no, inhibiting sodium channels. And when the positive cannot enter, the inside of the membrane will become more negative, #hyperpolarization, #inactivation. We're trying to inactivate your nerves. The action potential is here. Do you remember the rapid depolarization? Yeah, who is responsible for that? Sodium entry to the cell, sodium influx. Who's gonna inhibit sodium influx? Yup, local anesthetics. How do they work? They inhibit the voltage-gated sodium channel, which inhibits the conduction of the action potential, and this happens through 3 steps. First of all, local anesthetics, they cross the cell membrane. Alright, so in order to cross a membrane, you have to be lipid soluble, in other words, non-ionized. And of course, you know from pharmacology that the same drug, just one drug, can be present in a non-ionized form and ionized form at the same time. So which one is entering? Only the non-ionized, only the lipid soluble. Alright, local anesthetics are weak bases. There is a rule in chemistry that says like dissolves like. There is a rule in pharmacology that says like reabsorbs like. So if these drugs are bases, you gotta put them in a basic medium in order for them to be reabsorbed or like pass through membrane. In other words, when you put a base in a basic medium, they become unionized, aka lipid soluble, aka capable of crossing membranes. What kind of membrane are you talking about? The membrane of the neuron. Now they have entered into the neuron. Welcome to the promised land. From the inside of the neuron, they will bind to the sodium channel. And then what? Once they bind to the sodium channel, they will stabilize it in the inactivated state, because the sodium channel has 2 gates and has 2 states, the activated state and the inactivated state. So, you know what, sodium? You will remain here. Okay, just stay still. Stay in the inactive state. You mean I'm not allowed to activate? Nope, you're not allowed. Just shut up and be inactive. Oh, and by the way, this was the same mechanism of class 1B antiarrhythmics. If you want to learn more, check out my cardiac pharmacology course on my website, medicosisperfectionalis.com. Here's the beautiful sodium channel. You have the resting state, open, which is the activated state, and then the closed or inactive state. What does the local anesthetic do? It keeps it in the inactive state. It traps it. It freezes the sodium channel in the inactive state. Actually, it's more complex than this because, as you know, the sodium channel has 2 gates. Alright, one gate is called the active gate and one is called the inactive gate. We'll talk about that more in my playlist called Physiology. Local anesthetics, esters or amides. How do I tell which is which? The name has the enter. If the name goes like this, an X followed by cane, a prefix followed by cane, such as pro-cane, cocaine, tetracane. How about the amides? No, this is different. This is the prefix and then a combination and then the root and then the suffix, such as prilocane, lidocaine, pubivacane, mepivacane, ropivacane. Esters versus amides. How are they metabolized? Esters are metabolized by plasma esterases. This is genotypic polymorphism and there is hypersensitivity, especially to the freaking PABA, para-aminobenzoic acid. The amides, on the other hand, are metabolized in the liver P450 system. In the good old days, which were not so good, this was known as the liver microsomal enzyme system, but now we call it the P450 system. So it's the liver's job to get rid of these amides. So what if I have liver disease or cirrhosis? Oh, you will not be able to metabolize them. What's going to happen? They will pile up in your blood, increasing the risk of toxicity. Please note that cocaine does not require the addition of epinephrine. Why not? Because cocaine on its own has an intrinsic, self-sufficient sympathomimetic activity. And this explains why cocaine is capable of causing severe vasoconstriction, especially if you are a crackhead. And this severe vasoconstriction will deprive your nose of blood supply, especially the nasal septum, because you're snorting it. And this can lead to nasal septal perforation. This is very high yield for your exam. Cocaine is a local anesthetic. We know this. It's an ester. Moreover, it also inhibits the reuptake of norepinephrine. Therefore, norepinephrine is going to accumulate and pile up and remain in the synapse, which will increase the activity of norepinephrine. As you know, norepinephrine loves to hug and kiss the alpha-1 receptor, causing vasoconstriction, and this can lead to nasal septal perforation. After learning about all of these horrible facts about cocaine, do you think we use it clinically as local anesthetic? Nope, not anymore. Why not? It's an irritant, it's a vasoconstriction, it can lead to nasal septal perforation and dependence. And that's why pharmacists are the crackheads of the hospital. They are drug dealers. They just do it legally via prescription, instead of illegally under the bridge, aka under the counter, no pun intended. Do we use cocaine? The answer is no. Do we use benzocaine? The answer is no. Why? Poorly water soluble. How can I hasten the onset of the local anesthetic? Add bicarbonate. Why? It has to do with the pKa and the pH. Oh my goodness, I hate this stuff. Shut up. It's easy. Let's review some math. When I say that A equals B over C, you know that between A and B, there is a direct relationship. Between A and C, inverse relationship. How about B and C? There is a direct relationship as well. If B goes up, C will go up as long as A remains constant. Similarly, A plus B equals C. From this equation, you can deduce that between A and B is an inverse relationship, A and C, direct relationship, B and C, direct relationship. To summarize this in just two rules, whenever you see two entities divisible by each other or subtractable from each other, there is a direct relationship between them. Whenever they are multiplied or added to each other, there is an inverse relationship. So here, the relationship between A and B is direct. Why? Because they are divisible. You can get A over B. It's possible. So let's replace this with this. When I say that pH is proportional to bicarbonate over carbon dioxide, the relationship between pH and bicarbonate is direct. In other words, if bicarbonate goes up, what's going to happen to pH? It's going to go up as long as carbon dioxide remains constant. Nice. You can replace this proportional sign with equal, but you have to multiply by a constant. So this will be A equals constant times B over C. And now you have replaced this with an equal. You can do the same thing here. Remove this and we'll replace it with a constant. The constant here is pKa plus log of whatever over whatever. The base over the acid, and the rule still applies. If bicarbonate went up, what's going to happen to the pH? It's going to go up. What if bicarbonate went down? pH is going to go down. But if bicarbonate went up, pH is going to go up. You know why? Because these two entities are divisible by each other. There is a direct relationship here. But look at these two entities, the bicarbonate with the pKa. Oh, they are added to each other. And whenever two entities are added, there is an inverse relationship between them. In other words, as bicarbonate goes up, what's going to happen to the pKa? It's going to decrease. We call this the Henderson-Hasselbalch equation.
Okay, medicos, I still don't understand. Why should I add bicarbonate?
Okay, follow me. When you add bicarbonate, what's going to happen to pH? It's going to increase. Let's do it here. When you add bicarbonate, pH is going to increase. But between the bicarbonate and the pKa, there is an inverse relationship. As you add bicarbonate, pKa is going to go down. The more bicarbonate you add, the greater the pH and the lower the pKa is going to be. And there is a rule that says the lower the pKa, the higher the percentage of the unionized fraction of the drug at a certain pH. When you added bicarbonate, what happened to the pKa?
It decreased.
And when the pKa decreases, what's going to happen to the percentage of the unionized?
It's going to increase.
So when you add bicarbonate, the percentage of the unionized portion of the local anesthetic is going to increase, and you will have more lipid soluble fraction, more unionized fraction. Still not convinced? Remember this slide that we have discussed before? Whenever you put a base in a basic medium, you're making it non-ionized, aka lipid soluble, which can pass through membranes because the membranes are lipid bilayer, and this will favor reabsorption or passage through membranes. You already know that local anesthetics are basic. So whenever you put local anesthetics, basic, in a basic medium, they'll become non-ionized, aka more lipid soluble, aka more capable of passing through membranes because they are lipid, and this will favor the entry into cells. So as you add bicarbonate, pKa is gonna decrease. This will increase the percentage of the unionized fraction of the local anesthetic, which will increase the lipid soluble fraction, which will make it easier for me to pass through membrane and enter into the neuron and inhibit the sodium channel. And all of this will happen faster just by adding the bicarbonate. See, medicine makes so much sense once you understand what the flip you're talking about. If your woke professor explained it like this, I will retire from YouTube and start peddling nice statin swish and swallow with mint flavor under the counter. It tastes so good, you guys. I am so tempted. Some rules. Lipid solubility and potency are directly related. If the certain anesthetic has a greater lipid solubility, there is increased potency. If there is increased lipid solubility, there is increased duration of action because it's passing through membrane, increasing its volume of distribution. How about protein binding? The greater the protein binding, the greater the duration. How come? Because protein is a carrier, right? If this is a local anesthetic binding to the carrier, of course, it's gonna stay longer. It's being retained. Do you remember the nerve? Yeah, it had endoneurium, perineurium, and epineurium. Endo on the inside, peri, the middle, epi on the outside. Oh, by the way, where did we get these three layers from? They are the extensions of the pia mater, arachnoid mater, and dura mater as the nerve exited from the brain or the spinal cord. Wrap your head around this, no pun intended. Suppose that this is a big nerve. Imagine like the median nerve. Okay, the median nerve has all of these fibers and it's like a very, very thick internet cable. And it has some internal fibers and external fibers. The external fibers supply the proximal muscles, leaving the internal fibers to supply the distal parts. Think of it as the median nerve getting thinner and thinner and thinner as you go distal and distal and distal, and it's losing its covering one step at a time. Now, if you are injecting local anesthetic and here is your lovely needle, which part of the nerve is going to be affected first? External fibers or internal fibers?
Of course, external because they are closer.
No duh. And that's why the patient will lose sensation in the proximal parts before the distal parts. See, it makes sense if explained properly. We have three types of nerve fibers, A, B, and C. Who's the thinnest? C. Who's the first to be affected by the local anesthetic? C. Who carries pain sensations? C. C fibers carry post-ganglionic autonomic and pain fibers. How about B? This is the preganglionic. How about A? Myelinated somatic. And A is divided into four subtypes: A alpha, A beta, A gamma, A delta. Let's do it. A fibers are the myelinated fibers, motor fibers, proprioception fibers, muscle tone fibers, and the fibers responsible for fine touch sensation. How about B? Preganglionic autonomic. Could be sympathetic or parasympathetic. How about the unmyelinated thinnest, which is C? Unmyelinated postganglionic autonomic. Could be sympathetic or parasympathetic. They also carry pain, temperature, and crude touch. So let's talk about pain fibers. Pain fibers could be C or they could be A delta. We can dig deeper. Okay, pain, C fibers, temperature, A delta, touch, A gamma, deep pressure, A beta, motor function, A alpha. A alpha is the best. That's why you give it to motor, because it's important for survival. If you're running from a tiger, you need motor fibers. These are the thickest, fastest, most robust fibers.
Why don't we have all of our fibers A alpha since they are the best?
Because myelin is stinking expensive and there are no solutions in life. There are trade-offs. Economics is the study of scarce resources which have alternative uses. If all of our fibers were A alpha, you would be as obese as a dinosaur, and the dinosaurs are extinct.
Okay, Medicosis, shut up. I'm injecting the local anesthetic. Which fibers will be affected first?
C fibers, and the patient will lose pain sensation first. Amazing. And then what? A delta, temperature is gone. A gamma, touch is gone. A beta, deep pressure is gone. A alpha, motor function is gone. Most of the time you will not go that far. So the freaking dentist, when he injects you with lidocaine, for example, you will feel no pain because the C fibers get knocked out first. However, you are still able to open your mouth.
Hey, open your mouth, son.
And then the dentist can start working in your mouth. And they always keep asking questions while all of their tools are in your mouth, and they expect you to answer these questions. These people need to get their heads out of their collective sphincter. As you increase the firing rate, as the conduction velocity increases, this will increase the effect of the local anesthetic, and you will go from here to here. If you have watched the previous videos in this anesthesiology playlist, we have repeated the slide ad nauseum.
Why do we add epinephrine to the local anesthetic?
We have pros, we have cons. Let's talk about the pros. Because it decreases absorption, it keeps the local anesthetic in place, it increases the duration of action, it decreases the toxicity because we vasoconstricted, it decreases the bleeding because we vasoconstricted. Moreover, epinephrine is alpha-2 agonist, decreases the release of substance B, decreases pain sensation. Is there anything in life without side effects? Heck no. As Dr. Thomas Sowell once said, there are no solutions in life. There are incremental trade-offs.
So what are the disadvantages of
Adding a vasoconstriction to the freaking local anesthetic. What's the problem with adding epinephrine? Don't forget, epinephrine is beta-1 agonist. Oh, cardiac arrhythmia can happen. Epinephrine is alpha-1 agonist and beta-1 agonist. Oh, it might increase the blood pressure. And if I suffer from hypertension before the procedure, that might be a problem. Moreover, if you constrict so much, you get ischemia, and this is especially dangerous if you're injecting the epinephrine in an area with poor collateral circulation or poor anastomosis. Example, digital nerve blocks in your fingers and your toes. Who metabolizes the local anesthetics? Liver. Therefore, liver disease will lead to what? No metabolism, increased toxicity.
Now tell me about the toxicity of the local anesthetics.
There is CNS toxicity, cardiovascular toxicity, and others. CNS toxicity, you inhibited the nerves, you inhibited the cortex. Oh, and you inhibited the cortical inhibitory pathways. Cortex has many functions, including to inhibit you. And that's why when you're drunk, you're freaking alcoholic, you lose your inhibition. And you start opening up, uttering crazy nonsense. When you inhibit the inhibition, you get excitation. Well, no duh. The loss of a loss is a gain. The negative of a negative is a positive.
CNS excitation to the point of
Seizure. And then this excitation is followed by depression, which can lead to death. Cardiovascular toxicity. This is like the antiarrhythmics class 1B. So they decrease cardiac activity. They also decrease smooth muscle activity. This can lead to vasodilation, which can lead to hypotension, which can lead to cardiovascular collapse. Don't forget, cocaine has intrinsic sympathomimetic activity. It's a strong vasoconstrictor. It can perforate your nasal septum. A vasoconstrictor will increase my TPR, increasing my blood pressure. Also, a vasoconstriction causes ischemia. Side effects of these doofuses: allergy, cross-sensitivity, systemic toxicity, cardiovascular toxicity. They cause hypotension. cardiovascular depression. Widen the QRS complex and they prolong the QT because they are inhibiting everything. The essence is to inhibit the sodium channel. Hashtag hyperpolarization, hashtag inactivation. Everything is slow. CNS toxicity can happen, such as circumoral numbness, slurred speech, tinnitus. Who else caused tinnitus? What's the name of the other drug? Oh, aspirin. Restlessness, vertigo, seizures, excitation followed by inhibition. Now it's time to talk about neuromuscular blockers. Please revisit video number 1 in this series. I've told you the story of the indigenous peoples of South America. They used to dip the arrow in some kind of a liquid and then use it to paralyze their prey. What was that? A neuromuscular blocker. This was curare, and it was observed that a donkey could survive this poison if artificial ventilation was provided. Therefore, this poison caused what? Respiratory paralysis. That's why the donkey survived if you ventilated. Why does curare cause respiratory paralysis? Because it causes diaphragmatic paralysis, because this is a muscle. It's a skeletal muscle. What do skeletal muscles have? N sub M receptor. What kind of neurotransmitter? Acetylcholine. Choline, therefore they are cholinergic. Acetylcholine is being released and it's gonna jump onto the N sub M receptor at the neuromuscular junction because we're talking about skeletal muscles here. After acetylcholine has performed its job, thank you so much, cholinesterase enzyme is gonna take it to the cleaners. What's the name of that space? Motor end plate or neuromuscular junction. How do neuromuscular blocking drugs such as curare work? They basically inhibit the N sub M receptor. N because it's nicotinic, M because this is a muscle, skeletal muscle that is. Make believe that this muscle is your diaphragm and you will end up with respiratory paralysis, preceded by a restrictive lung disease. That's why curare, historically, was used to treat spastic paralysis in cases of rabies and tetanus, because in both of these diseases, you're so stiff, your muscles are contracting too much. Oh, let me block the contraction. And this is the most amazing slide in this video. It's part of my autonomic pharmacology course on my website, medicosisperfectionalis.com. How does tuberculin work? Well, it has curare in it. It's gonna block the N sub M receptor at the neuromuscular junction, and of course this is a cholinergic receptor. Why do we use neuromuscular blockers? During tracheal intubation to relax the muscles, and during abdominal surgery to relax the muscles. Neuromuscular blockers, let's go. Why do you use them? Surgical anesthesia, facilitate tracheal intubation. They are neither analgesics nor anesthetics. They are only neuromuscular blockers. They will not make you unconscious. They will not make you painless. That's not their job. How do they work? They block the N sub M cholinergic receptor at the neuromuscular junction for skeletal muscles. We divide these drugs into two groups, non-depolarizing and depolarizing. Depolarizing is just one, the doofus succinylcholine, which causes malignant hyperthermia, which is treated with dantrolene. How about the non-depolarizing? We have short-acting, intermediate, and long-acting. Short-acting, mevacurium. Intermediate, atracurium. V-curonium. Rocuronium. Cisatra. Curium. Who named these things? Long-acting, pancuronium, because the word pan means what? Extensive, inclusive. Case in point, pancytopenia. Panhypopituitarism. Panoramic view. Pancakes, panarthritis. How many examples do I need to give you before you get the point? Oh, and it's probably why we called pans in your kitchen pans as opposed to pots, because pans are wide. They are more general, more inclusive. After all of this, if you forget that pancuronium is long-acting, I will smack your gluteus minimus, metaphorically speaking. Let's talk about the non-depolarizing. Alright, what's the problem? Competitive antagonist of N sub M. Okay, what does that mean? Can you reverse them? Yeah, if you're competitive, you can be reversed. Go back and watch my video on pharmacodynamics. How do I reverse them? Give them someone to compete with them. Okay, who can compete with them? Acetylcholine will compete with it. How? You have to preserve it. How do I preserve it? Inhibit its inhibitor. Block its destroyer. Oh, inhibit the acetylcholinesterase? Absolutely. Give neostigmine, for example. Non-depolarizing agents can cause progressive paralysis. Lucky for us, they have no effect on cardiac muscles or smooth muscles. You know why? Because they only work at N sub M. They only target nicotinic receptors, not muscarinic ones. There is no change in consciousness. And these are your examples. Next, depolarizing, the one and only succinylcholine. How do you work? I'm an agonist at the nerve. What? An agonist and an antagonist? Yeah, but let me finish because I have phase 1 and phase 2. Alright, phase 1, activation. So you're activating the skeletal muscles? Yep, I cause fasciculations of these muscles. You want to make it worse? Add an acetylcholinesterase inhibitor such as neostigmine. I'll give you even more fasciculations. Because now there are two persons acting on the N sub M. Succinylcholine and acetylcholine. That was phase 1. But wait, there is phase 2. Desensitization. The receptor will get sick and tired of being sick and tired. You know what? Screw it. I'm gonna get blocked. I'm not gonna contract anymore. You will end up with paralysis. Can you antagonize the paralysis? You can try by giving me acetylcholinesterase inhibitors such as neostigmine. But please don't wait until it's too late. Succinylcholine not only works on the N sub M, it also works on N sub N and on muscarinic receptors, and that's why it can affect cardiac muscles and smooth muscles. How do you get rid of succinylcholine? Same way you got rid of acetylcholine. You mean by the cholinesterase enzyme? Absolutely. Where do you find it? Liver and plasma. But what if the patient has deficiency of the acetylcholinesterase enzyme? Oh, please don't give them succinylcholine. What's gonna happen if I do? If you give them succinylcholine and they don't have the enzyme to metabolize it, succinylcholine is going to accumulate and pile up and increase, causing prolonged paralysis, which can even lead to apnea. We call this succinylcholine apnea. Moreover, succinylcholine can lead to skeletal muscle injury, and of course, muscles, like any cells, have potassium in them because potassium predominates in the intracellular fluid, not in the extracellular one. Rupture the muscles. Muscles release potassium into the blood, you will end up with hyperkalemia, which can lead to arrhythmia. So succinylcholine can cause two disasters, succinylcholine apnea and malignant hyperthermia. We have talked about malignant hyperthermia before. Remember the triad. Tachycardia, increase in tidal CO2, and hyperthermia. Everything is increasing. How do I manage it? Stop the freaking succinylcholine and give dantrolene. You have two types of the acetylcholinesterase enzyme, true and pseudo. The true is found at red blood cells and cholinergic nerve endings. How about the pseudo? The pseudo with the P is in the plasma with the P. Can I have deficiency of this enzyme? Absolutely. It could be congenital or acquired. Should I order the acetylcholinesterase enzyme level in the blood? Sure, if you want to detect the pseudocholinesterase deficiency. Why pseudo? Because this is the level that's in the blood. You're doing a blood test here. Why should I order it before anesthesia? Because if you give succinylcholine and the patient has pseudocholinesterase deficiency, what's going to happen? Succinylcholine apnea. Prolonged muscle relaxation, even with the normal dose of succinylcholine. Also, you can measure the level of this enzyme to detect and to identify those who have been exposed to organophosphate poisoning. To learn more about acetylcholinesterase enzyme, check out my playlist called Labs. Bonus time, some natural toxins. Tetrodotoxin versus batrachotoxin and ciguatoxin. Let's start by tetrodotoxin. This is a marine toxin. How does it work? Inhibit sodium channel. How do I diagnose it? Go to the lab, they will tell you. How about these two doofuses? They inhibit the inhibition. Oh, you mean they excite? Absolutely, causing hallucination. How do I diagnose them? History of ciguatera consumption.